kind of wanted to start with a case. So this is just to kind of jumpstart what we're talking about. So this is a 48-year-old woman who comes to the emergency room with jaundice and confusion. Her family states that she's been just fatigued for the past 1 week and then became progressively jaundiced over about 5 days. She has pretty limited medical history with just high blood pressure. She takes hydrochlorothiazide. She did have a sinus infection about 6 weeks ago, at which time she was taking Augmentin. She does not have any known liver disease in the past. And her exam is notable for the fact that she's visibly jaundiced. She's ANO times 2. She has no evidence of pulmonary erythema or spiders. Her liver edge is palpable, but the spleen is not. And her initial labs are notable for an AST of 190, ALT 372. The bilirubin is 9.5 and INR is 2.0. The acetaminophen level is undetectable, pregnancy test is negative, and then some initial testing for viral hepatitis comes back negative as well. So I think, this is a kind of patient where it's reasonable to think about acute liver failure, right? And why is that? So I highlighted some of the things that come up, I think, especially in the history and based on the labs and the exam. So she right off the bat has evidence of jaundice and altered mental status. It seems to be a short time frame where this has happened. On exam, she does not have any stigmata of chronic liver disease, which is kind of based on the exam of her hands and skin, and then of course the fact that her spleen is not enlarged. And then if you look at her labs, the more concerning thing beyond the fact that her liver enzymes are elevated is the fact that she already has pretty significant coagulopathy. So while we'll go through a little bit later that there are other conditions that can present in a similar fashion, especially in a patient that's unknown to us. Acute liver failure is something to consider in a patient like this. So for the purpose of the talk today, these are kind of the sections that I wanted to cover. First was to just go over the definition. Second was to briefly discuss the etiologies and if there are specific therapies for some of these. Next, we'll talk about diagnosis and how to evaluate the patients. That will be followed by how to manage them. And then a little bit at the end about prognosis for these patients, kind of where is the role for liver transplant. And I'll just touch briefly at the very end about long-term outcomes because that's some newer information that's come up in the past 10 years. So let's start with the definition. What is acute liver failure? Acute liver failure is kind of, it's of course a short-term condition in most cases, but essentially it's a patient who shows up with some evidence of liver injury based on labs. Usually they have elevated liver enzymes, plus minus their bilirubin. They often have, they by definition need to have coagulopathy, which means that their INR has to be 1.5 or greater, and they need to have encephalopathy. So if you have evidence of liver injury with coagulopathy and encephalopathy, and on top of that, the patient does not have any known history of cirrhosis, and this has been a short-term condition, then that's how you make the diagnosis. Now, if you look at AASLD, for example, guidelines, sometimes they'll define acute liver failure as being acute even up to 6 months or so. I think in most cases, patients are usually going to present within days to probably max 4 to 6 weeks if you really look at most of the patients that we see. Now, one of the difficulties in making the diagnosis, of course, is that when you get a patient who shows up yellow and confused, in most cases, it will not be acute liver failure, right? I mean, most of the patients that we see on the floor tend to have decompensated cirrhosis, and I think unfortunately these days, a lot of severe alcoholic hepatitis. So how do you tease this out, especially if you don't have any history about the patient beforehand and they show up confused and are unable to provide many details? So acute liver failure, once again, there should not be really prior liver disease. It should be a recent onset of symptoms. I guess there could be an overlay with alcohol, especially in these Tylenol overdose patients, but usually it's not a patient who has like significant alcohol history. On the other hand, if you talk about severe alcoholic hepatitis or decompensated cirrhosis, we hope that we know that these patients have some form of liver disease or chronic alcohol use. in both cases, they'll probably have some sort of stigmata of chronic liver disease, and there may be more of a subacute or kind of chronic presentation. And then, there's the occasional other things that masquerade as acute liver failure, and those can include kind of oddball hematologic conditions, including HLH, lymphoma, et cetera. And those can be very difficult to tease out. We've had other patients where we've initially started transplant evaluations assuming they had acute liver failure, and then it became apparent over time that they had things like HLH. And so you can look for specific kind of markers like elevated LDH and ferritin and things like that. But one of the important reasons that you want to make the diagnosis of ALF early is that if you look at the second row, the time to death really varies, right? So patients with ALF, we usually measure their survival in days compared to alcoholic hepatitis and cirrhosis, where patients can, of course, be very ill and some can die very quickly, but oftentimes we have weeks to months to try to get them to transplant. And because of that, patients with acute liver failure, once listed for transplant, actually get the highest priority because the need for transplant is so emergent. If you look at the prevalence of ALF, fortunately, this tends to be a pretty rare condition. So in the United States, it's up to maybe 3,000 cases a year, and kind of similar numbers if you look in the United Kingdom. So in any given year, we probably aren't seeing a lot of these patients, and there's probably a reasonable chance that if you're rotating through the ICU, you may not see one in the month that you're there. So let's move on a little bit to diagnosis. So once again, on the left side of the screen here, this is a patient who shows up with elevated liver enzymes and maybe bilirubin. They have coagulopathy. They have altered mental status, so you're considering acute liver failure. At that point, there should be a pretty low threshold to send the patient to the ICU, and we'll talk a little bit more about why that is. I think it's partly for the kind of intensive care the patients do need. And then for listing purposes for transplant, it's actually necessary for the patient to be in the ICU if they have acute liver failure. And then, this doesn't really pertain to us because we are a transplant center, but if you go on to work somewhere else where you are not a liver transplant center, and you find a patient like this, there should be kind of an early call to transfer the patient to a liver transplant center. So, in most cases, if you're doing a history and exam, it can be limited, especially if the patient shows up alone. But if you have family or somebody else to kind of talk to, you can ask about whether there's been any recent medications or toxin exposures, if there's been any recent viral infections, and then kind of quickly confirm that they don't have any prior liver disease. And then the lab testing, I won't go through all these individually, but of course you want markers of their liver function and look for coagulopathy. And then a lot of the other testing is kind of related to transplant listing and to look for an etiology for liver disease. So speaking a little bit more about etiologies, what the cause of acute liver failure really, it depends on where you live in the world. So in other parts, such as like Asia, for example, the vast majority of ALF cases can be attributed to viral hepatitis. And that can include things like hepatitis E that we don't see a whole lot here. But Hep B and hepatitis E make up more than 50% of the cases in Asia. And even in Africa, you can see a good amount of viral hepatitis. On the other hand, if you look in Western Europe, especially the United Kingdom, and then here in the United States, almost half of the cases that we see are related to acetaminophen overdose. And probably for those of you who have seen these patients in the ICU, most often the ones that show up are typically some form of Tylenol overdose. So as long as you're working here in the Western Hemisphere, I think if a patient shows up, you right off the bat probably want to rule out Tylenol overdose. And so because of that, I kind of divide up the specific etiologies into Tylenol and other things. And what are the other things? Well, there's kind of a long list that includes things like mushroom poisoning, so amanita mushrooms, which do grow in this area. And I'd say once every few years, we have had a patient show up with ALF related to that. Some forms of idiosyncratic drug injury to the liver, viral hepatitis, Wilson disease, autoimmune hepatitis. And then, there's other things that are much less likely, like acute fatty liver pregnancy. I think we've had, maybe at least one case earlier this year, I remember, in a pregnant woman, of course. Probably plenty of shock liver that you've seen in the ICU, and then rarely things like Budd-Chiari or malignancy. So let's talk a little bit about acetaminophen, since it's the most common cause of acute liver failure here in the United States. It's generally been thought that you need to take more than 10 grams a day of acetaminophen to actually develop ALF, but it's become increasingly apparent that some people may need to take less than that, sometimes even maybe 3 or 4 grams a day, which is still like the upper limit of what you're allowed to if you look at the labeling on the bottle. Now, some of this may be related to patients who also consume a fair amount of alcohol. They're sometimes primed to develop ALF with less amounts of acetaminophen. I think in general, for the patients that you see, when you see these once in a while, you may be inclined to think that most acetaminophen overdose are intentional kind of suicide attempts. But if you look at the data in the US, it's probably kind of an even split between intentional overdose and then what's called therapeutic misadventure, which basically means patients who kind of accidentally take too much acetaminophen. I think we see that more in people who are drinking alcohol, and then you also see that more nowadays in patients who take narcotic preparations that also include acetaminophen in there, or sometimes when patients take over-the-counter cold medications when they're not feeling well, and then don't realize there's acetaminophen in that cold medicine and then take Tylenol on top of that. The RUMAC nomogram, which I kind of put here, was the mainstay kind of way to figure out liver toxicity from Tylenol overdoses in the past. And what you would do is you would draw the patient's blood and check their Tylenol level, and then knowing how long ago they ingested the Tylenol, you could kind of get a sense of if they were going to have liver toxicity or not. But there are some problems with this tool. One is it kind of one thing is that you don't always know when the patient ingested the Tylenol unless somebody witnessed it. Two is, this whole nomogram is made on the assumption that somebody has intentionally overdosed at a single time point. But I think, nowadays there are patients who could be taking, kind of more moderate to high amounts of acetaminophen across many days and then develop toxicity. And this nomogram isn't really built to evaluate those patients. If you look in the United States, the patients that tend to show up with acetaminophen overdose overall are younger. They tend to be white, and you tend to see more women than men. And once again, there's kind of this split between intentional and unintentional overdose, but there is a significant overlay of alcohol use and probably overuse or abuse. There's a significant kind of proportion of these patients that use narcotic medications that include acetaminophen, and then probably a pretty high overlay of psychiatric disease, given the high amount of antidepressant use in these older studies. So if you have a patient who has acetaminophen overdose, if it's been a short time, which it often is not, there is a role to give activated charcoal in the emergency department. But if you don't fall within that time frame, then really the only treatment that we have is to give N-acetylcysteine, and that can be given either intravenously or orally. A lot of these patients, because of altered mental status or nausea or things like that, it makes it difficult to give them the PO version. So I feel like we default to the IV. One question that always comes up with this is kind of how long to keep somebody on N-acetylcysteine when they have acute liver failure. And that still hasn't really been fully worked out and is kind of a point of controversy. Some people look at the transaminase levels to make that decision. Some people kind of look at the INR. I think just based on my own training from a while ago, I default to using the INR. So I typically will keep the N-acetylcysteine going until the INR kind of gets back down to 1.5 or lower. Unless you're running into a lot of issues with volume, for example, then sometimes, if it's under 2, we may just stop the N-acetylcysteine if the patient's very fluid overloaded. So just briefly talk about other etiologies. If you look at kind of acetaminophen overdose versus other causes of ALF, there are some clues in the patient's clinical presentation that might kind of alert you to one cause versus another. So as I mentioned before, patients with acetaminophen overdose tend to be a bit on the younger side. But the other thing that you can kind of elicit from their history is that they often have a very short duration of symptoms and jaundice. So that's, usually within just a couple of days of when this happens, or even less than that, depending on if they overdosed a massive amount at once. On the flip side, if you look at other kind of causes of drug injury, antibiotics, for example, or other causes, there's usually a little bit longer there's a longer time period between the exposure to the inciting kind of trigger and then this development of symptoms. So that can sometimes even be 2 or 3 weeks. In general, the acetaminophen overdose patients will have markedly elevated transaminase levels. So if you really, somebody shows up with AST, ALT in the several thousands, acetaminophen should really be high on your list, whereas, if it's kind of more in the 300-400 range, you should of course check, but it seems less likely. These patients tend to kind of have probably a little bit higher INR at presentation, and often they'll have a much lower bilirubin compared to a lot of these other causes, probably because it's such an acute form of injury. And there's also kind of more of a tendency to develop a kidney injury earlier in the patients with acetaminophen overdose. So if acetaminophen kind of has been excluded and you don't really have an etiology based on the history, you can kind of think through what else could cause ALF, and this is just kind of a list of all these things. So, drug-induced liver injury, you're really stuck based on the history. Of course, you would withhold whatever the offending medication is, such as the antibiotic. I will highlight that, in the past, there used to be a push to try to give these patients steroids because why not? But I think there really isn't a lot of convincing evidence that steroids help these patients, and a lot of these ALF patients are high risk for infection, so I would tend to avoid that. Viral hepatitis, of course, is kind of standard testing for hepatitis A and B. Depending on kind of if travel history or if they have other risk factors, you could think about hepatitis E. And then if the patient's very, very ill, don't forget about things like herpes. Autoimmune hepatitis, we can send off the usual serologic testing, which includes ANA, smooth muscle antibody, IgG, which is usually elevated in these patients. The only problem is that, about a third of patients with kind of fulminant autoimmune hepatitis will have negative serologies. And so if you really suspect that somebody has autoimmune hepatitis and acute liver failure, sometimes the question comes up, should they get a liver biopsy? And then do you consider giving them steroids? And that's always tricky because they're so coagulopathic, of course, so getting the biopsy done is difficult. And then given the risk for infection, steroids are always kind of tricky. My own thought on this is that I think patients who present with pretty severe autoimmune hepatitis, if they still have normal mental status, even if they have, say, ascites or something, or they have significant coagulopathy, but their mental status is intact, and you can prove it on a biopsy, I think it's worth giving steroids. We've seen some of those patients kind of salvaged with medical therapy. I'd say if the patient truly has acute liver failure where their mental status is already gone, there's little evidence that steroids really helps. And so in those patients, I think really the plan should be more towards transplant and should avoid steroids given the infection risk. Wilson disease, of course, a hallmark kind of board's answer to testing is ceruloplasmin and that being low. I will tell you, however, that ceruloplasmin can be low in other causes of acute liver failure, so you may have to do additional testing. And just to point out that there's really no role for chelation therapy in patients with fulminant Wilson's. They have to get liver transplants. Mushroom poisoning, there are some limited treatment options. In fact, there is a way to get a compound called silibinin out of state for us through a study protocol. For acute fatty liver pregnancy, there are specific criteria, which I just listed here, the Swansea criteria. If you ever see a pregnant woman or considering this, and of course the answer is always with a pregnant woman with liver disease on the boards is to deliver the fetus. And then patients who have acute ischemic hepatitis or malignancy usually are just sick for other reasons and are not really good transplant candidates because they have limited survival because of other things that are going on. We talked a little bit about the role of N-acetylcysteine in acetaminophen overdose, but it turns out that NAC actually has a role in acute liver failure of other causes as well. And this was kind of the big study from about 12 years ago that looked at patients with ALF and giving them NAC, and also when you gave them NAC. And really, I think the highlights of this were that N-acetylcysteine can improve survival in patients with ALF, even if it's not related to acetaminophen. And secondly, it does matter when you start the NAC. So giving N-acetylcysteine early when they have, grade 1 or grade 2 hepatic encephalopathy, there's definitely a survival benefit. If you look at the other lines, for example, giving N-acetylcysteine once the patient is intubated and has more profound grade 3 or grade 4 encephalopathy, there's really no difference versus placebo. So I think the big message would be any patient with acute liver failure should be started on NAC. And if you're going to start the NAC, you should start it right away as soon as you suspect that the patient has ALF. Just a quick word again on the role of steroids. This was a retrospective study that looked at whether steroids help in acute liver failure. And if you look at the blue and red lines, they were looking at different etiologies such as autoimmune hepatitis and drug-induced liver injury. And you can see that there really was no significant difference in survival overall for patients who did or did not receive steroids. When they looked specifically at patients who were spontaneous survivors, so that means patients with ALF who did not require a liver transplant, that's the green and purple bars, you can see there was maybe a trend towards improved survival in those patients. The problem was that the numbers were very small in the study. And so none of this kind of reached any statistical significance. And I'm not aware of any other newer data that really supports steroids. So I would say in ALF patients, there's probably very little reason to experiment with steroids. A quick word on Wilson disease. So, a lot of the things that you learn about from a textbook that are helpful to make the diagnosis, such as a low ceruloplasmin or Kaiser-Fleischer rings, that's not always true in real life. So in patients with Wilson disease, only about half of them actually have that the signature Kaiser-Fleischer ring. And it's much more common in patients who have like a neuropsychiatric presentation rather than patients who primarily have liver disease. The ceruloplasmin can be low also in about half of patients who have acute liver failure due to other causes too. So it's not surprising to get a low ceruloplasmin right off the bat. And so, what are other clues for these patients? Well, one is these patients can have higher than expected bilirubin, and often it will be more indirect. And that's because they're prone to developing a Coombs negative hemolytic anemia. And the other part that's kind of interesting about these patients is that for somewhat unclear reasons, they can have very low alkaline phosphatase. So if you have a patient with ALF and you see a kind of very low alk phos and a higher than expected bilirubin, think about Wilson. And so really at that point, you may need more confirmatory testing, which includes like a 24-hour urine copper. This can be difficult if the patient has, oliguric or anuric renal failure. Or you can quantify hepatic copper, but that once again requires a liver biopsy, which is difficult because they're coagulopathic. But it's important to know that if somebody really has fulminant Wilson disease, their only definitive treatment is liver transplant. There's no role for chelation. And without transplant, this is universally a fatal condition. And this kind of just talks about the same thing. So let's move on a little bit more to general management of ALF patients. So of course, all of these patients by definition have hepatic encephalopathy. And this is just a chart going through how we grade hepatic encephalopathy. And so, sometimes grade 1 can be very difficult to tease out. The patients may just have kind of minimal changes. They may be laughing inappropriately, just things that are a little bit off. Whereas, of course, grade 3 and 4 is much more obvious where the patient is nearly obtunded or comatose. And it is important to know their grade of encephalopathy because, as I put in the column on the right, it directly correlates with their risk of herniation, which is a major cause of mortality in this patient population. Now, for those of you who have rotated either through the clinics with us or been on the inpatient hepatology service, you probably noticed that we don't really follow a lot of ammonia levels in the kind of chronic cirrhosis population. And that's because, venous ammonia levels are notoriously unreliable. And so we usually treat patients with traditional hepatic encephalopathy based on their symptoms. If we look at ALF patients, however, there is a role to follow ammonia, but it's actually the arterial ammonia. And this is one study that has shown that patients who have kind of a higher arterial ammonia level over 200, they have a high risk of intracranial hypertension and subsequent herniation. And so, a lot of these patients, because they're in the ICU and so sick, will most often end up with an arterial line at some point. So this is one other marker that you can follow, beyond their pH and lactate and things like that. And arterial ammonia, whenever you're getting ABGs on the patients, can be a good idea just to kind of stay ahead. On the if we kind of look at these patients who have low-grade or early hepatic encephalopathy, these are the general management strategies. So you usually want to keep them in a quiet environment and minimize agitation. This is because anything that kind of gets them more riled up can cause their intracranial pressure to go up. You want to have close monitoring of their mental status and move them to the ICU, where they should be getting neurochecks at least every 2 hours. You want to avoid any kind of medications that can impact their mental status, including kind of sedating medications. It's worthwhile to get a baseline head CT, and that's not really to look for things like cerebral edema or herniation, because if you find that, it's usually too late on imaging. But more to really exclude other kind of causes of mental status change, such as intracranial hemorrhage. And then, one question that always comes up is there a point to giving medication to reduce the ammonia, like lactulose, that we give to the cirrhosis patients? And there are some mixed results about this. There are some studies that suggest you can improve, at least temporarily, the hepatic encephalopathy with lactulose. The problem is that the mechanism of encephalopathy in ALF patients is very different than the general cirrhosis population. And I think on a more practical kind of standpoint, lactulose tends to cause a lot of gas and bloating. And if you assume that most of these patients will likely need a liver transplant, the surgeons are usually pretty unhappy when they go to the OR and open up the patient and then they just have tons of dilated bowel in the way. So I think in general, we would not advise giving lactulose if you think somebody has acute liver failure. What happens if the patient progresses and kind of has more advanced encephalopathy? Well, first is, as always, remember airway protection and intubate the patient. It can become very difficult once they're intubated to kind of get a better assessment of their mental status. But as far as you can, doing frequent neurochecks is important. Once again, kind of minimizing moving the patient around or agitating them. And then it's worth keeping the head of their bed elevated to kind of reduce intracranial pressure. If they have seizures, this is a little bit old, you can use things like Dilantin. I think nowadays we use Keppra a lot more. And then, a somewhat controversial topic is whether to use ICP monitoring. So if you think about it, your cerebral perfusion pressure in your brain is related to your mean arterial pressure minus the intracranial pressure. And most of these ALF patients will have rising intracranial pressure. In general, you want to keep intracranial pressure less than 20, and you want your cerebral perfusion pressure to be greater than 60. But the problem with all of this is, ICP monitors, older studies suggest that they do improve the time that the patient survives, but ultimately it doesn't really impact whether you die or not. So it may kind of buy you more time in terms of management until they get transplanted. But if they don't get a transplant, then they usually die. And the other problem with this is, as you would probably expect, is given the coagulopathy, there's a significant risk to placing these monitors. And one of the difficulties is that the monitor becomes more accurate the deeper you put it in. So in other words, if you actually put it into the brain parenchyma, you get the most accurate readings, but of course that's the highest risk of bleeding and death. We actually had a discussion with the neurosurgery team at Georgetown a few months back about this topic. And I think they are pretty hesitant to put these in, and I think maybe appropriately so, in that their arguments are, one, we don't have a lot of data to support putting these in and that it really helps these patients, and two, kind of that they're worried about all the risks of bleeding and things like that. So I think the consensus right now, at least from neurosurgery at Georgetown, is not to go after putting these monitors in, but that really, whether or not to use monitors is center specific. There are ways to medically manage advanced encephalopathy. There are things like mannitol and then hyperventilation. The problems are hyperventilation is something you can only do for a very short period of time. Mannitol is something you can only try once or twice, and there are contraindications, including things like it can lead to hypernatremia, and it's difficult to do if the patient has renal failure. The intervention that has the most data behind it is hypertonic saline. And so if guidelines from AASLD, kind of the major liver society, is to consider prophylactic hypertonic saline in patients who are high risk with acute liver failure. And they define high risk as those patients who have high arterial ammonia, as we talked about before, advanced encephalopathy, so like patients where you actually already have intubated them for encephalopathy, if they have acute renal failure, or if they're on pressors. So the really kind of sick, more advanced patients, it's worth considering hypertonic saline. And if you do, you would be, I think in most cases, probably we would use like 3% hypertonic saline. And the goal would be to drive up their serum sodium to the 145 to 155 range. So I think that's one thing that we could probably try to be more aggressive about in our patients at Georgetown. In other places that I've been, people have experimented with kind of cooling patients and using therapeutic hypothermia. There's only really like one retrospective study on this that's small, and I think they tried to look at 21-day spontaneous survival, and really there wasn't a clear benefit in patients who got the cooling, the hypothermia, versus those who didn't. So, some places have continued to use this. I don't know that there's a lot of evidence behind using it in ALF patients. As I mentioned before, acute liver failure patients have pretty significant risk for developing infection for both actually bacterial and fungal infections. So you should probably have a low threshold for starting empiric antibiotics, especially if the patient has a kind of worsening mental status, if there's concern that they have SIRS or sepsis. And there's plenty of evidence that developing kind of SIRS itself may exacerbate their encephalopathy. That being said, there's not a lot of evidence that there's benefit to starting antibiotics prophylactically. If the patients aren't on antibiotics and things, I think it's worth considering periodic surveillance cultures, every 48 to 72 hours. Just given that these patients are at such high risk to develop infection. A few quick points on coagulopathy. As we talked about, sometimes it's difficult to tease out if a patient when they present has ALF versus something like cirrhosis or alcoholic hepatitis. And just to complicate things more, you would usually expect the patients who have more chronic liver disease with portal hypertension may have low platelets. The problem is that in the ALF patients, sometimes acutely, they can have low platelets too. There may be some subclinical vitamin K deficiency in these patients, so it's worth trying to replete them. Although in most cases, the INR is probably not going to respond if they have pretty significant liver failure. Transfusions in general should be reserved for invasive procedures, and it's worth just avoiding unnecessary transfusions just to correct the INR, especially if the patient's not bleeding. One issue is, of course, it's a lot of volume, especially if they have renal failure. Two is, the INR is a very important marker for us to all follow to know whether the patient's improving or not. If the patients become hypotensive, it's the usual management of giving fluids. And I put in kind of consider dextrose, because remember that a lot of the patients with more progressive liver failure are prone to hypoglycemia. You can use pressors as needed, and really you want to keep the goal mean arterial pressure on the higher end, maybe even as high as 75. And remember, that's because if the intracranial pressure is high, the only way you have to try to keep the cerebral perfusion pressure up is to do some of the other things that we talked about to reduce ICP. And then the one other option you have is to drive up the mean arterial pressure to kind of keep up with the high ICP. You want to prevent kidney injury, so of course avoid kind of nephrotoxins like contrast, etc. You want to treat infections and keep the blood pressure up. And then if the patients progress to the point that they need some form of renal replacement therapy, in general, there's evidence that CVVH is a better option than intermittent HD. I think a lot of these patients, because their blood pressure tends to be low, there really isn't an option. But once in a while, even if they have kind of quote unquote normal blood pressure, CVVH is preferred mostly because you don't get the big fluctuations in blood pressure drops and things like that can impact the risk of herniation if they have high intracranial pressure. Of course, keep an eye on the blood sugars, like I mentioned, because of the liver failure. You can keep an eye on their electrolytes and supplement them. Sometimes actually having a low phosphorus level could be a good prognostic sign suggesting liver regeneration. And then, of course, keep up with their nutrition. So let's move on to prognosis. So knowing the etiology of the acute liver failure is also important, not only because it affects your management, but because it correlates with prognosis. So, if you look across, in general, patients with acetaminophen overdose probably have the best survival, although you can still see a quarter of the patients actually do die here in the hospital. But the biggest difference you see across all causes is really the transplant-free survival, right? So if you don't die right away from the acetaminophen overdose, there's a pretty good chance that you could recover with just medical management. And very few patients end up needing liver transplant. On the flip side, if you have ALF due to almost any other cause, there's a pretty poor spontaneous survival rate. And so most of those patients will need liver transplant. So if you have somebody come in and it's not a Tylenol overdose, I think it's even more important that the transplant evaluation should start right away. And so, I just kind of mentioned towards the bottom that there's a rapid evolution of outcomes in patients with acetaminophen overdose when they have ALF. So they're, of course, more likely to survive spontaneously, which is a good thing. But paradoxically, they're actually more likely to die awaiting transplant, and they often die very quickly within a couple of days versus acute liver failure from other causes. But overall, this patient population is very sick. And if you look, their median time to death from when they show up in the hospital is well less than a week. And because of that, the median time to list them for transplant is usually very short. In fact, there's some of these patients we've actually successfully listed for transplant in even 24 or 36 hours, just knowing how ill they are. If you look at prognosis for these patients, there are different models to look for prognosis. The kind of old and most traditional was to use King's College criteria. There's a little bit of data about using the MELD score, although it's not well supported. And then there's a newer model called the Acute Liver Failure Study Group model. And this is just a quick chart that shows you kind of what the different variables that go into each scoring system. But if you look across all of these, I think the things that kind of come out of this is that the etiology of the ALF matters. You need some sort of marker of their disease severity or rate of their disease progression. And then, occasionally the age does factor in as well. So King's College criteria, this is kind of the old criteria for ALF that was developed in the 1980s. And they actually have two sets of criteria. There's one for acetaminophen overdose and then one for everyone else. So this is a little more straightforward. So for acetaminophen overdose, having significant acidosis with a pH of less than 7.3, or within the first 24 hours, having high-grade encephalopathy, an INR over 6.5, or creatinine over, and a creatinine over 3.4, are very poor markers, or poor signs, and suggest that the patient will ultimately need a liver transplant. The criteria for other causes of ALF from King's College, it tends to get a little bit more difficult to either remember or use, so you'd have to probably look this up. But essentially, if the patient has pretty advanced encephalopathy and coagulopathy, which is similar to what we see with Tylenol, you would think they need transplant. Or they have this other kind of set of criteria where if you have three or more of the following, where patients are kind of on the extremes of ages, they've had a more delayed, there's a delay between when they first develop jaundice and when the encephalopathy comes, and then have high INR, high bilirubin, or an unfavorable etiology, which they define as things like Wilson's disease or drug-induced liver injury. I would say, one of the things that kind of stands out here, like the development of jaundice more than 7 days before the onset of encephalopathy. We've seen that actually a lot in patients. Usually these are the patients who have autoimmune hepatitis or those who have drug-induced liver injury not related to acetaminophen. Those are patients we've seen who've come in, told us about kind of jaundice that they've had, and sometimes they even show up not encephalopathic. And then, on day like 6 of admission, they'll suddenly become very altered or even obtunded. So those patients always make us very nervous. A quick word on MELD score. This is the only study I'm aware of, and this is from Pakistan, where they looked at MELD score in ALF patients and said that it found that it correlated pretty well with the King's College criteria. The problem is it's kind of small study. It's only about 90 patients. They did not have any patients with acetaminophen overdose because that's not really a thing over there. And basically, most of the patients had hepatitis B or hepatitis E, so these are not really the types of patients that we see here. So MELD score probably has some correlation, but how well it works here in the US, I don't know. And then finally, the newest kid on the block is this ALF study group model, and it includes these 5 variables that I listed, which include having grade 3 or 4 hepatic encephalopathy, which is similar to, like the King's College criteria, etiology, need for pressors, and then it uses the log of the bilirubin and the INR. And the nice thing about this criteria is, one, it did perform better than all the other ones that I've shown you when they're compared head to head. And two is there's actually a free app that you can download for this acute liver failure study group on your phone. And it's pretty easy. You kind of just check off yes, no on all of these things. And it gives you a 21-day expected survival for your patient. So it's a pretty kind of easy and useful way to know prognosis when you're in the ICU and you're taking care of a patient like this. So now that we talked about prognosis and kind of the importance of liver transplant, let's talk a little bit more about liver transplant for ALF. So of course, you want to list these patients urgently if they're poor prognostic signs. We know about a third of ALF patients may recover spontaneously. And in fact, up to 20% of patients that are listed for transplant with ALF may still survive spontaneously. The problem is that we're not very good at figuring out which of these patients are going to get better without just waiting and seeing. Overall, the good news is that transplant-free survival has been improving in the US, and that's probably due to kind of more improved care in the ICU because of, you guys in the ICU team, maybe more kind of better use of N-acetylcysteine and giving it earlier, et cetera. But there's still pretty significant mortality in the ALF patients, especially those where it's not related to acetaminophen. When we list these patients for a liver transplant, I just kind of wrote this down. This is the requirements to list a patient as status 1A, which is basically kind of the highest status you get on the liver transplant list. And acute liver failure patients do meet this. And basically it says that the patient has a life expectancy less than 7 days, which most of these patients do, that they have fulminant liver failure without pre-existing liver disease. And then I would just highlight that in here, it says that the patient has to be in the ICU, which is why we really make a push to keep these patients there. And then they have to meet one of the 3 criteria at the bottom. They either have to be on the ventilator, they need to be on dialysis, or they have to have an INR greater than 2.0. And I'd say, many of the patients kind of meet several of these criteria, but in general, I think most of these patients have an INR over 2. So if their INR is over 2 and they're in the ICU, they by definition will meet the requirements for listing them as status 1A. And then finally, just a few quick words on long-term outcomes, just because this is something kind of was near and dear to my heart. In prior research that I had done with the ALF study group, we had looked at these patients who survived ultimately after they had ALF. And if you compare them to patients with cirrhosis who undergo liver transplant, the patients with ALF that underwent liver transplant continue to actually have more depression, anxiety, and PTSD, and they're more likely to remain unemployed, which is kind of odd if you think about it, because they usually have kind of a sudden event, and then and they were healthy before, and then kind of do well after transplant, as opposed to patients with cirrhosis who've kind of been sick for a long time. But if you compare them, if you compare other spontaneous survivors, if you compare to other spontaneous survivors or patients who underwent liver transplant with ALF, the acetaminophen overdose ALF patients who spontaneously survived also had more depression, anxiety, and pain, which may not be surprising to you. And they continue to have a high rate of psychiatric disease and substance use even after they spontaneously survived the ALF episode. So this kind of brings me to the end of the talk, and I think these are kind of the key points, hopefully, that you picked up today. For acute liver failure, early diagnosis is important. You want to rule out other conditions that have similar presentations, like alcoholic hepatitis, or perhaps a cirrhosis patient where they've had an acute, there's a more acute condition like sepsis that's caused them to get sicker. N-acetylcysteine should really be given to all patients with ALF, regardless of etiology. If you're not at a transplant center, this patient should be transferred to a transplant center early. If they have more advanced encephalopathy, don't forget to intubate them. If they have progressive renal failure, continuous renal replacement therapy is preferred. Remember that they're high risk for infection, so you should have a low threshold for antibiotics and even antifungals if they clinically deteriorate. And then transfuse only if they have active bleeding or need for invasive procedures, because remember, the INR is an important marker that we want to follow for prognosis to know how the patient's doing.